Okay, we're fantastic. We're going live now. So welcome everyone. We'll just give a minute or so for everyone to join, and then we'll begin. So good morning, good afternoon, good evening, everyone. Welcome once more to another EPI-WIN webinar. Today we will have discussions on cholera treatment strategies to decrease deaths. And for that, we have eminent experts. Opening the webinar today is Dr. Nedret Emiroglu, who's the Director for Country Strengthening and Readiness at WHO. Then we have Philippe Barbosa, who needs no introduction in the cholera community. He's the head of cholera here in WHO and also the lead for the Secretariat for the Global for Cholera Control. We also have Kate Alberti, another leading cholera expert, case management expert, and she will be talking about case management strategies, along with Gift Wondola, who's the community health specialist. So she will bring in the community aspect of case management there. Then we will have Jamie Rylance, who's another case management expert, and Beverly Lacher, who's an epidemiologist in Malawi, and who's also working on strengthening community health systems. And they will be talking about the Malawi experience. And last but not least, we have Vicky Husier, who's a risk communication and community engagement specialist, and she will be also answering some of your questions here. So we have a very dedicated team here. So before we go on to the webinar, some housekeeping. This is being recorded and also live streamed on YouTube. Please put your introduce yourself in the chat, but your questions, please put it on the Q&A. Those of you who regularly attend these webinars know the drill by now. And please keep your comments constructive and positive. You're welcome to share your views, but please keep it constructive and polite. Thank you. And without any further ado, I would like to invite Nedret to please give the opening remarks. Over to you, Nedret.
Yeah, good morning, good afternoon, and good evening to you all. And I see many of you joining us from all over the world. And thanks, Priya, for organizing this. And we're going to be discussing with you, bringing various global respected experts on cholera, global station. Philip is going to give you a feedback on where we are, and then some of the treatment strategies. And actually, I'm very sorry to be discussing such an ancient disease in the 21st century, still causing such a high morbidity and mortality. As you know, cholera goes back to 1800s, and then there has been really outbreak control and documented, as you would refer to John Snow's studies, and it has been in the textbooks as a disease with an ancient history. And here we are. We have been seeing cases last year and this year in all the regions of WHO except the European region, and quite endemic, and with the high number of cases in 31 countries, over 800,000 cases and almost 6,000 deaths. And you will hear more details from Philip on that. And despite that, there is a global movement that I'd like to give you a bit of an update on, the Global Task Force on Cholera Control, which has been established, revitalized actually in 2014, is a network of more than 50 partners active in cholera control globally. And it includes many agencies, academic institutions, non-government organizations, of course, many of the UN agencies. And the task force launched a strategy for cholera control, and we were aiming to end cholera with a global roadmap to 2030 in 2017. And as I said, here we are discussing still how to save the lives from a disease which is preventable, first of all. I think all the underlying conditions, the unplanned urbanization, the climate change, the infrastructure difficulties with water and sanitation, and many conflicts is resulting on these numbers, and many of these deaths which could have been prevented first of all, or treated later on, even if the infection is not avoided. So that requires a collaborative global effort to work together. And we are happy that we are working very closely with the Global Task Force on Cholera Control, which allows us to have collaboration and partnerships, many agencies. And I think also engaging the communities, the knowledge and changing behavior of the individuals is critically important. So today you will hear a lot more on the cholera case management, and hope that that's going to support all your work. Thank you very much. And I give the floor now to Philip Barbosa, as introduced by Supriya. He's the lead on WHO cholera program within headquarters. And he's also the head of the Global Task Force on Cholera Control Secretariat that I've been mentioning, this strong partnerships. And Philip, I think you're going to give us an overview on the response, on the epidemiology and response. But I assume there is a small quiz before we move to Philip. Is that correct?
That
I'm messing up the agenda. Sorry, Sophia.
That's fine. Thank you, Nudret. And yes, a small quiz just to see how well everyone's up on cholera. So let me just give me 2 seconds here. Oh, no, sorry, that's not the one. Give me 2 seconds here. Here we are. So if you could scan this or go to slido.com and put in hashtag 1883379, and we have a small quiz here, which the question is, can you see the quiz? Is the question coming up? It's live quiz. Wait. Some reason the question.
We cannot hear you, Priya.
Oh, apologies. If you could continue to respond to the quiz throughout the webinar, but now I invite Philippe Barbosa to give an overview of the global situation. Over to you, Philippe.
Yes, thank you very much. So waiting for the presentation to be broadcasted. So first of all, thank you very much, Nedret, for the very good introduction. I think it really set the scene of what we are talking about, and the challenge that we are still facing with one of the oldest known disease and and the middle age, situation that we are unfortunately still seeing. So, not going into much detail, but I think it's really important to take a moment to see where we are. And so you were, referring to the work done by the GTFCC, which again is bringing together many partners that have been engaged and that are still increasingly engaged in cholera control. So the GTFCC launched a roadmap in 2017, to support the engagement of country toward sustainable cholera control, and eventually, with an objective to eliminate cholera as a public health threat by 2030. So what you can see on the right graph is, from 2017 to 2020, there was a very marked progress despite the quality of the data, and we'll come back to that later, but and the challenge of having a good visibility of the number of cases and deaths that are occurring in the world, this situation has not changed. So although all these figures are grossly underestimated, you can see very clearly that there was marked progress. So here I represented only the number of cases, but that was the same for the number of deaths. And globally, between 17 and 2020, there was an overall almost reduction of almost 90% of the number of deaths reported worldwide. One country being excluded for Yemen because of some data challenges. But what you can see now, what is changing from 2020 is the exponential or close to exponential increase of the number of cases and also of the number of deaths that have been reported since 2020. Of course, 2020 was the COVID that has impacted also the many of the country, and in particular in deriving or depriving some of the necessary resource to the control and surveillance and case management of cholera toward COVID, and it was the same for many other diseases. But this is not the only problem. So the situation is so bad that since 2023, so now more than a year, almost a year and a half now, the global cholera crisis has been graded as a grade 3 emergency by WHO, which is the highest level of grading that can be attributed to any crisis. So this is a system that is used across humanitarian crisis or infectious disease crisis, but this is the highest level. So, and since almost a year and a half, we are in this very critical situation. So we'll see later on that the spread. So, but in short, the what we are seeing since the mid 2021 is this outbreak are more frequent, larger, and deadlier. So what we are seeing, and this is of course the topic of the day. So it's really that we are looking at outbreak with unacceptably high CFR. So for the one who might not be very familiar with cholera, without any type of treatment or case management, the CFR of cholera of severe cases can be up to 50%. However, with adequate treatment, the CFR should be below 1%. The 1% is not the target. The 1% is the maximum acceptable CFR. So the CFR should actually be much lower than 1%. And that will be re-explained by Kate and colleague later on. But the treatment of cholera is extremely simple. Okay, you don't need any ICU or very complex item. What you need is to rehydration and very important accessibility to healthcare. So cholera, as I mentioned, is clearly re-emerging. Not only we are seeing more outbreak in cholera affected country, the one that we know, but we are also increasing the number of countries that have not been affected for decades being re-affected by cholera. So again, underlying clear spread, global spread to new areas. So this is fueled by many factors. They are the intrinsic factor. The thing it's important to remember that when you have cholera outbreak, it's a sign of very clear vulnerability. Okay, so the thing which I really want to stress as well is it's not about no, can you go back? I don't know what's going on, but the fact that cholera is striking in a country, it's not just about eliminating a disease. It's a fact that, of course, we have to control this middle-aged disease. It's totally unacceptable in the 21st century that people continue dying just because they do not have access to a bag of ORS that cost a few cents, or just because they don't have access to case management. So this is totally unacceptable. Of course, what is also unacceptable, it's in the 21st century. People are still dying just because they are drinking water contaminated with feces. So the thing is, the global north and many of the other countries have eliminated cholera, just by improving water and sanitation. Okay, and Nerat, you were referring to John Snow, the typical, that all epidemiologists have learned, even not working on cholera. That was the first clear demonstration of the interest of epidemiology, but also of how we can, just closing a pump in London has stopped the cholera outbreak there. So the thing is, this is, controlling cholera is beyond reach. But more importantly, or as importantly, there is an immediate moral obligation for all of us to reduce cholera outbreak. as I have mentioned on the previous slide, the situation is getting worse and worse. This is fueled by, of course, conflict, urbanization, poverty, lack of development, etc., etc. So that are the known factors. But the thing that we are seeing more and more, and that explains a good part of the exponential increase of the case that we are seeing, is the impact of climate change. Most of the very large outbreaks that we have seen on the past 2 years, not all of them, but most of them had a direct impact, a direct trigger that was either a big flood, either a cyclone, either a drought, and sometimes several of them at the same time. So this is, of course, increasing population movement, either people fleeing flood or people looking for water in the case of drought, and of course, traveling with more risk of contamination and spread. So not only it's important to control cholera and again, not just for cholera but as a factor of vulnerability, because in area where you have large cholera outbreak, it means that you have no access to water. It means that you have no access to case fatality, to healthcare treatment. You have no sanitation. It's usually in the same area that you would have, according to countries, the highest malnutrition rate, the highest other diarrheal disease infection rate, the lowest other antigen immunization coverage, etc., etc. So cholera does not happen just by accident. So today, and this is, I really want to stress on that, it's an under representation of the number of cases that are really occurring because of lack of investment in surveillance. But we have almost 850,000 cases that have reported since the beginning of 2023, including just for the first months of this year, almost 140,000 cases. The number of deaths are also possibly even more underreported than the number of cases, because most of these deaths in many countries are still occurring in the community, while the number of deaths that are reported are in the vast majority only the ones that are occurring in healthcare facility. So we estimate that at least 100,000 deaths are occurring, and this is just done on modeling, etc. So you can see that even but still the number of officially reported deaths is clearly unacceptable. So since last year, there was 31 countries that were affected. We still have currently at least 23 countries that are affected, because again, cholera is a stigma, and there are a number of countries that refuse to recognize and declare the outbreak, including 3 countries in which we consider the situation is acute, with absolutely major risk for the population, increasing trend, and as I mentioned, increasing case fatality rate. Next, please. So the things which is very important is, cholera is a multisectorial, the response to cholera, the adequate management of cholera is multisectorial. So there is not a silver bullet. However, the means and resources that are required are, I would say, extremely simple. So the first one, and I really insist on that one, so unfortunately it's often the most challenging one, but to be implemented because of lack of interest of major donors and strategy. But the thing is wash. If people would have access to safe water and wash, we would not be discussing cholera today. Okay, so this is the long-term solution, and cholera, like the other diarrheal diseases, waterborne diarrheal diseases, should be controlled very easily and sustainably by providing access to safe water, sanitation, and hygiene. The second point, and I will keep the topic for the day at the end, but the second point which is important is surveillance and reporting. Of course, if we do not have enough capacity in the world to early detect and early response, we are seeing more and more outbreak. I always want to stress that, if all the countries in the world now can do a PCR on COVID, many, if not most of the cholera-affected countries do not have the capacity at least in provincial or state level, according to the country, to perform effective laboratory confirmation of cases. So this is something which is important. Of course, I'm sure many of you know that there is the cholera vaccine which is effective, but I'm sure also that many of you know that since 2 years now we have facing a massive shortage of cholera vaccine that prevent its use. So the vaccine is sufficient both for preventive and reactive vaccination campaign. But since at least a year and a half, we have not enough vaccine to do preventive vaccination campaign, but we also not have any vaccine in sufficient quantity to effectively control the ongoing outbreak. Coordination of partners, this is something which is important. And of course, community engagement. And I think this is very important. And this will be a topic that you will be discussing today, because we need to put, the community again at the center of all the strategy. Okay, so the thing is, we need to have, and we being all of us, to understand how we can better serve the most affected community, and especially the one that are totally neglected and forgotten. So that's require a massive investment. And when we are talking about community engagement, it's not about talking about having nice poster and t-shirt and caps. It's really what is needed. How can we make the community empowered to be part of the solution and to define the things that need to be implemented, and for them to understand the risk and to have the prevention measure. And the last one, but not the least, of course, is healthcare strengthening. Of course, having the capacity and the knowledge and the supply to be able to adequately treat patient in cholera treatment center, cholera treatment unit, but also, and very importantly, to have accessibility to healthcare at the community level. And in particular, a rapid and easy and seamless access to ORS to allow the patient to be transported to another places. As again, I really want to insist on that too many people just die because they do not have access in a good time to a simple bag of ORS. Next, please. So again, this is really to take with a lot of caution, but this is, of course, we are talking about case fatality rate, and I thought it was important to show you some of the figure we have. I think it's very important for you to interpret with caution this data, because, of course, the case fatality rate is extremely influenced by the way the surveillance system is designed in the different countries. So, and the way the case definition is applied. But you can see that in several countries, especially in Africa, where most of the countries are applying the recommended case definition and reporting, you can see that, on average, and this is an average, you can see several countries with more than one person, but including to an average of 3%, for example, in Zambia or in Zimbabwe or other countries. This is totally unacceptable. And when I say that, I'm not blaming the country. I mean, the situation in Zambia or in Malawi a few years before was just that the size of the outbreak was so big that it totally overwhelmed, the capacity, national capacity. So this is why we have to work very actively to avoid having situations like that. And country, like Zambia, like Malawi, and a few others, have been very much engaged in cholera control. But the thing is, again, because of climate change, urbanization, etc., the scope of the outbreak is so big that the traditional way or even the expertise that happened before are totally overwhelmed. Okay, so and that result again in extremely high CFR, knowing again that many of the deaths were not reported because they were happening in the communities. Next, please. So this is again another example of where the how the situation is occurring. Please again, this is not to blame this country, and I would say it's actually the contrary. At least we have to praise and to thank this country also for being very transparent in the information they share, which is not the case for all the country, and this is very important. So some countries are reporting very little CFR, but we know it's not correct. So these are examples of the situation we are facing, but again, with countries that are very transparent and honest about the situation that they are facing. So you can see that there is very often a big discrepancy in community. The number of deaths that the country are aware about most of the time exceed the number of institutional deaths. And for example, in Comoros, it's up to almost twice as much. So this, of course, allow to understand where the problem is. So this is driven by multiple factors. Sometimes people are, because of lack of engagement, knowledge, etc., are reluctant to go to the treatment center. But sometimes they also just do not have the capacity to go there because it's too far. Remember also for that cholera. This is one of the specificities of cholera. Cholera can kill within hours between the onset of symptom and death. So that can be very, very fast. So in situation where the population is not aware, like for example, it's a case of Comoros that has not been affected for cholera for a long, long time now. People sometimes think, okay, oh, it's a diarrhea, okay, but no, cholera is not just a simple diarrhea. Next, please. So again, a snapshot on data that we have. Unfortunately, I wish we would have this kind of data for all the countries. Far from being the case. But you can see that they of course, I mean, young children, not necessarily the under one because they are they are somehow in most instances, not everywhere, protected also by the breastfeeding. So children under 5, between 1 and 4, of course, have an increased case fatality rate, an incidence, but can be well controlled. So you can see here that there is a very marked difference between the number of cases and the case fatality rate, and it will be a surprise to no one that the CFR increase very sharply with age. Okay, so and we tend to forget very often that elderly people are very much at risk of die for many reasons that my colleague will explain, but it's more difficult to detect dehydration, etc., etc. Next, but again, just so that was the last one, but when we need to be shocked, we need to make this voice, seeing in even any age band to see case fatality rate of 20% for a disease that we can treat. Voilà. So the last word I wanted to say is, of course, this is a very gloomy situation, but this is not lost. We know what to do. We have all the resources to do it. So the fight against cholera is not lost. So we need to continue. We have all the resources at our level. We just need to make sure that people have access to healthcare. And in the current setting, because of climate change, lack of vaccine, etc., we cannot control necessarily the outbreak the way we want. At least we all have a moral obligation to prevent all deaths. So all cholera deaths are preventable with the means we have. Thank you very much for your attention.
Thank you very much, Philippe, for that excellent overview. The message is clear. We all have a moral responsibility to reduce cholera deaths. It's preventable, and key messages that what you said about too many people dying because they don't have timely access to a simple bag of ORS, and the need for early reporting and surveillance for early detection. Very clear messages there. Thank you very, very much. We now go on. Well, need for early reporting and management of cases. So we now invite Kate Alberti to talk about cholera treatment strategies. What are the strategies that we can take up to prevent more deaths? Over to you, Kate. And then we will have Q&As after Kate and Gift's presentations. So we will discuss your questions. Thank you for bringing them in. Over to you, Kate.
Thank you very much. And thank you to Philippe. I mean, I will just be highlighting some of the key messages that he raised during the presentation. And my presentation, as you just said, is really joint with my colleague Gift Ndombula, who is from Malawi, and we work together there. And she is both a community health specialist, was also a member of an affected community, and that's really the reason that we're really happy to have her here today, as she has that double perspective. So what we'll be doing is going through, I'm going to give the very minimum just to give a kind of build a little bit on what Philippe said in terms of cholera, looking at a global overview of cholera deaths, looking at it in a slightly different way than was presented by Philippe. The overall treatment strategy, not in terms of treatment protocols, but in how do we reach patients, as Philippe mentioned, that's really one of the critical elements, before handing over to Jamie and Beverly, who will be looking at how some of the more clinical aspects of cholera. So I think the 2 points I really want to highlight here, just so you see it visually, in text as well, of what Philippe said, is that
I'm sorry to interrupt, Kate. Could you put your slides on presentation mode, please? It seems to be coming up.
Okay. Should be. It should be. Are they not? Okay, seems to be okay now. Is that correct? Okay, I see. Yeah, okay. I think it's okay. So if somebody could just send a thumbs up, a little thumbs up icon, that would be all right. But I think what we wanted to say is, perfect, thank you. Is, as Philippe said, this is really a disease. It's I'm not going to go into the transmission. He really covered that in terms of, people not having access to clean water and sanitation. This is really the absolute basics. But what I do want to mention just is how much of cholera can be treated outside cholera treatment structures. I think when we think of cholera, that's the immediate thought is about these big cholera treatment structures, the tents that are put up, the patients who have severe dehydration. And yes, we must think about that. But if you look at it, 80% of the patients who have symptoms of cholera can be treated, have either no or very mild signs or mild to moderate dehydration, and can be treated with oral rehydration solution alone. And I think it's a really important figure to keep in mind. So the patients we're seeing in a treatment structure and who need to get that very rapid treatment in a setup structure where they can be treated with intravenous rehydration, it's 20% of the patients. So if you realize how many of those patients don't need to be in that structure, then it gives you a real vision of how important this community structures are and how we can keep as many people as close to home as possible and still get adequate treatment. I think the other thing that is sometimes, again, this was raised by Philippe, but is really important and is sometimes lost when we're thinking about treatment strategies, is the rapidity of the development of the disease. So you can literally be fine in the morning, start having some diarrhea, and you can die of dehydration in the evening. And that also has a major effect of how you set up the treatment. It's not like a disease that evolves over time, that you're not feeling very well, but maybe I'll wait. Maybe I'll be okay and I'll go tomorrow, or somebody's not available to take me. We'll wait until the evening to go to seek treatment. And for cholera, the patient may lose their life if they do that. So just that's another critical element when we're looking at how to set up strategies. And it's also another critical element in terms of the community engagement, because those decisions need to be made at the family level as well about going and seeking care much more rapidly than they would for another disease. Are you now seeing I have a feeling you're not seeing the screen. I need to just see. Let's see. All right, so apologies, you didn't see the first juice. Well, that's okay. You heard me, and we'll just have to live with that. So this graph, I think this is the Global Task Force on Cholera Control, the Case Management Working Group. We set out to do a scoping review to look at the literature and see whether there were confounding effects, whether people were dying because they had co-infections, whether they had underlying diseases, those kind of things. The first shock we had was that there was very little data available in the literature. So that's something any of you who are working in the field, please do analysis, the basic analysis of your data, and publish it. Because in fact, much as we think cholera is a very well-known disease, there's still a lot of questions and unknowns. So during that scope, that review of the literature, we had to sort of change tack and say, okay, looking at the more detailed clinical aspects aren't going to work, but let's look at what's happening. What can we find out about the deaths? And this graph was actually the second big shock. Yes, what you see in green, this is from a number of different countries. So it's but 10 countries from across the world. These are studies that are range from 1991 through to 2018. They're from the Americas, they're from Africa. So it's not from Asia, so it's not just one country. And what you see in green are the deaths that are occurring in facilities. And again, these are deaths that are reported. And I think what Philippe mentioned as well is also critically important, that in some of these places, we don't know. Is it because people are getting to facilities and that's where they're dying, or is this just the information that's being reported? So those are the deaths that have occurred in these contexts. The ones in green occurred in a facility. So we still have work to do there to reduce the number of deaths. But what really was shocking to us was the orange deaths. So these are the ones that are occurring in the community. The dark orange are those that are occurring literally in the community, and the lighter ones, they're in the community, but they were actually on their way to seek care. So I find that, when I saw this for the first time, I was really taken aback. We know this is limited data. We know that there are always going to be some issues of whether the death was actually from cholera or not, and that's often raised. But I think it still shows that this was really what sparked us to look much more closely and to be asking countries to be reporting, where are these deaths occurring? Because this helps us then improve strategies to be able to ensure that people are reaching care. So for me, this was sort of a very critical piece of work, and a graph showing this just very visually shares that really important, the real importance that it's a two-part. To reduce deaths has two major parts. One, about improving clinical care in facilities, and the second, why are people dying in the communities and what can we do about it? And that's really what I'm going to hand over to Gift, is going to be presenting more of that, but just go on. Sorry, wrong one. There we go. So what do we do now in terms of the strategy of treatment? So what are we doing to ensure that people do get it? Most of you know this, but again, I think it's important to review. A cholera treatment center, actually, I'm going to go the other way, because for me, the base of this triangle is where we should have the most emphasis and where we should be contacting the most people. And that's in the community. So the bottom two levels of this are oral rehydration in the community. And that doesn't mean that you have to have any kind of technical knowledge. It just means that we've got ORS in the community. People know to make it, know how to make it, and they know that as soon as they have diarrhea, they should start to take it. And we know this for children. IMCI programs, childhood diarrhea programs, that message is out there. But when you ask people whether that's happening for adults during cholera, that's much less well known. And that's a message that we need to pass. And then once they start ORS, they should go seek care. But starting that ORS is a critical piece of the puzzle. The next level up is oral rehydration points in the community. And this is somewhere that I'm not going to give details as I gift will, but this is ensuring that people who can stay in their community, do stay in their community, and they don't need to go to a higher level care. As Philippe said, 80% of those who have cholera can be treated with oral rehydration solutions alone. They don't develop the severe kind of typical, what we think of as typical. In fact, the majority of patients who have cholera don't have that typical presentation with severe dehydration. They've got diarrhea. It's it's very liquidy, but they can take oral rehydration solution. Many of them can be treated in their own community by members of their own community who are skilled. And then the few that need to go to another level of treatment can be sent to that next level of treatment. And that next level is the cholera treatment unit. These are centers where you can get oral rehydration, but you can also be treated with intravenous rehydration. And you do need to have quite a complex setup in terms of IPC. You've got to have beds, you have to have cleaning staff, you've got to be able to feed the patients, etc. It's not complex in terms of needs, medical needs of oxygen and other, but you do have to have a structure, and that has to have a strong infrastructure to make sure that the patients are in as best conditions they can and are getting the best quality of treatment they can. And then a cholera treatment center has the same capacity as a cholera treatment unit. Globally, they're just bigger, but they may also have another level of medical treatment. So you might have either a CTU, so a cholera treatment unit might not have medical staff. We hope it does, but they may be nurses and medical assistants, whereas a cholera treatment center usually does have at least some medical doctors, and they hopefully will have just a little bit more where they can capacity to treat some of the complications that patients may have. And I think what we like to see, this is one way of viewing it, is this triangle where the base is held in the community, and that's where the focus should be. Well, part of the focus should be. And another way of seeing it, and I apologize, is my great design skills, and in fact, my PowerPoint had even rejected this schema at one point, but it's really this idea of a network. So you've got transfer, and you can't forget that part. You've got to have that transfer capacity from one level for the people who need it to the next level of care. And I think one of the key messages we want to pass here is people know about ORPs. People who worked in cholera know about oral rehydration points in the community, but it tends to be seen as a second point. And I think my key message before handing over to Gift is that it cannot be a second stage. Yes, when an outbreak is evolving, and maybe you've got a lot of patients, you have to be building those structures so that you can treat patients with severe disease who are developing severe dehydration, and you need to have the capacity to do that to save lives. But just because you're not counting, maybe at the beginning you're not counting the community deaths, doesn't mean they're not happening. And that this whole network, this whole network needs to be developed at once. It's not a one step after the other. You have to have teams who are working on ORS and working on finding the skilled people within the communities who can deliver ORS and treat the patients who don't need IV rehydration yet, at the same time as you're setting up cholera treatment centers and cholera treatment units. And I think that's something that we have seen in the field quite frequently, is that there's an initial emphasis on the more, I think where we're more, medical teams are more used to working in a hospital environment, and that's maybe where they are focusing. But in fact, you need to have a parallel team, everybody working together, ensuring that you have this community aspect as well. Now, I'm going to end there, and I'm going to try and do a better job of sharing Gift's presentation, because she's going to take on much more about what does it mean, what is an oral rehydration point, and what is the role of the community, which is in setting them up. Are you seeing Gift's presentation? Online again.
We only see
I'm sharing my screen, Kate, with Gift's presentation.
Okay.
Can you
Thank
see
you very
it?
much.
Oh, no, it's not open.
Sorry, Supriya, it's not showing up.
It's not showing up. Can you see it now?
Yes.
Okay, great.
Okay. Thank you so much, Kate, for the presentation. It's true, we really need to focus on the community. And guys, I'm going to take you through the ORPs, which are community case management interventions for cholera or for diarrhea. So what is an ORP? We are saying it is a point of entry at a community level to treat and refer acute water diarrhea, including cholera. You should be able to handle a significant number of suspected cholera cases. It should be able to treat simple cholera cases, such as those in Plan A, able to stabilize severely dehydrated cases before referring to the CTC or CTU. Next. Yes, an ORP is a visible structure, as we can see. That should be opened at least 8 hours or more, depending on the security of the area. It should have access to treated water, sanitation, that is latrine, and close infection prevention control measures. It should be managed by the community nurse, a trained community health worker, and volunteers. It should be incorporated at the beginning of an outbreak to the end. We should not think of ORPs when the outbreak is out of hand. Then we're not going to control this community death at all. So let's focus on ORPs right away from the beginning of the outbreak. On our response, let's include ORPs. That should help us. Next. So who are the staff? What are supposed to do at ORP? Staffing capacity at an ORP. Staff must be able to apply case definition. They should be able to assess the level of dehydration and able to identify patients who should be referred or transferred to the next level of care. They should be able to initiate an IV line in severe cases or ORS as per protocol in cases which are moderate. Any additional staff are still welcome at ORP as long as they have a rightful training. In cases, and whenever possible, staff in ORPs should be from the same community. We should not take staff outside the community. Next. So, how to set up an ORP? Setting up an ORP, let's make sure that setting up an ORP, first we should have a functional guidelines and SOPs so that all partners should follow it, and assessment too. We also have to have, we should regard this as a multi-sectoral approach. whereby all pillars should be involved. We are talking of risk communication and communication engagement, RCCE, IPC WASH, surveillance pillar, case management pillar. Of course, not forgetting community leaders. These people, they are the focal people in the community because it's a community-owned facility. So let's involve community leaders right away from the beginning. We should have a supervisory committee at a national level. Also, we should have trainers of ORP. Of course, we should have a budget for ORPs. We should not just be thinking of ORP without a budget if we really want to deal with this community. We should have a clear referral pathway and also an exit strategy. People should know where to go from ORP. Next. So we are saying, what are the elements for us to make an ORP successful in our community? First of all, is community participation. Let's engage community. This increases their effectiveness, uptake, and sustainability. We can talk to them, have a meeting with chiefs, religious leaders, even influential groups in the community. There are people in the community, when they speak, all communities hear what they speak and they follow it. Let's use these people. Let's involve them. The ORP should be accessible. Let's make sure that community leaders choose location for ORPs. Let us give them chance to choose locations, whether they want it to be in CBBs, in churches, in marketplaces, whether in disaster-affected areas or in IDPs. Let us give chance for community to choose where the ORP should be, so that those in need should be able to access it without a problem. Let's also make this ORP culturally acceptable. This ORP should be accepted culturally appropriate. Do not use volunteers from a different village to operate an ORP. No. Make sure people who are using the ORP, they are the volunteers from the same community. When feasible, make sure local leaders should select their own volunteers. Our duty is just to train these selected volunteers so that the users should get confidence and sense of ownership that these ORP belong to us because they are our own people who are managing it. And then we should integrate these ORPs with the existing health system. The ORP should not be a separate entity. So when we integrate this ORP, it will increase its uptake and efficacy. Let's ensure that these ORPs, they are integrated. People, they should also know that from the ORP, what is the next stage? Where do they go? How do they go there? We should provide clear referral systems. They should know how and where to go. And who is supposed to provide the transport from ORP to a CTU or CTC. We should intensify health education. Information is key in each and every situation. Before setting up an ORP, let's involve RCCE. Let's train these people who are going to be managing the ORP. Let's orient them. Also, we have to give right information to the community. Let us teach the community signs and symptoms of cholera, signs and symptoms of cholera, and how to assess the level of dehydration. We should be able how to prepare ORS, how to administer using the local available resources. In addition, we should be able to have resources to manage these ORPs. This should not open an ORP today, tomorrow there's no RS at ORP. we should be able to provide supervision on this ORP. Let's keep an eye on these ORPs, how data is being collected, how many cases per day, and where are these cases coming from? How knowledgeable are these people managing the ORPs? Where possible, let us provide on-site mentorship to the people managing the ORPs during our supervisory visits. In summary, we are saying ORPs are crucial in treatment of dehydration caused by conditions like diarrhea, including ORS at community level. They assist in replenishing lost fluids and electrolytes, preventing serious complications like organ failure. ORPs are cost-effective, easy to manage, and it's easy to administer ORS. And it can be life-saving, particularly in low-resource areas and in areas where access to the facility is not easy. It is an easy-to-use tool, but yet powerful in compacting dehydration-related illnesses and saving lives, particularly in children and vulnerable population. Thank you.
Thank you very much to Kate Alberti and Keith Dondola for that very nice presentation. Kate, I look at your slide, and especially that slide where you show the number of people who died en route. I mean, that's quite heart-rendering. And Keith, thank you for your presentation that shows the critical role of ORP, cost-effective, life-saving, and how people can approach that. So we have quite a few questions. We have more than 30 questions already. And I request everyone to please put your questions on the Q&A. Before we go, can we just take a short break here and go through a few questions before we move on to the experience from Malawi? So the first question, I'll go in order, is from Trish Shang, and she talks about using CFR as a basis for whether or not to respond. In Mozambique, she says, for instance, last year the CFR never surpassed 1%, but we knew it was more than the health system could handle. So any comments on that to Philippe and to Kate? Should CFR be the basis for whether or not to respond?
Thank you. I think Philippe unfortunately had to leave, but I can answer that. I think there are two things, is that I still believe that CFR is an extremely good indicator, but how it's used needs to be adapted. So I know of that example, and I think that saying that a country doesn't get funding because they have managed to keep the number of deaths proportion, so a CFR low, is unacceptable. The 1% is, as Philippe said, it's the sort of the maximum target. What we're really, the real target, the maximum acceptable, the real target is 0 deaths. And it's something that their new GTFCC surveillance recommendations have come out. And one of those is to look at facility CFR and community deaths, and to report those separately so that we can actually see more clearly and this where the deaths are occurring, and then adapt the response as necessary. And I think that's a really critical element. I think CFR still helps orient. If you have an issue with CFR, even in a facility, it can be a number of things, and then it orients you to go investigate and have a look. It could be that the staff aren't trained. It could be that there's a lack of supplies. It could be that patients are dying very soon after admission, and that's an issue of access. So there are a number of different things. So I think it's yes, I still think CFR is a critical indicator, but how it's used, I absolutely agree that we need to look at that and ensure that countries aren't being missing out on funding opportunities because they're managing. And as you said, I think one of was also said is that, and Philippe said this as well, is trying to encourage countries to report. And as he said, all of the data that we've shown, those countries should be really, we appreciate the fact that that data is shown and we can see it, because as we said, in many countries, they're either reporting cases that aren't cholera, which then changes the denominator and can falsely decrease the CFR, or they're not reporting many either cases or deaths. And I'm also, just to say, I'm trying to answer some of these questions in the chat as I go as well. Thank you very much.
Thanks very much, Kate. There are lots of questions. We can't go through all of them, but there is a question on ORP, which I will ask a gift. It's unfortunately in chat, so please write your questions on Q&A and not chat, because this could have been missed. It was just fortunate that I saw it. Is it typical at an ORP that people can set up an IV line?
Yes, the answer is yes, because that's what we are encouraging to say in severe dehydrated cases. Somebody who is a nurse can set an IV line, but that should be like a stabilization point to say you put an IV and you refer that patient. But when there's no nurse at ORP, please refer that patient straight away. Give ORS and refer. And ORP is more like a stage, it's not a facility.
Sorry, I'm going to jump in on that. There are two different types of structures, and I think we have to be very clear that in 95% of, well, in all ORPs, there is no capacity to put in an IV line. And I think it's really, you still need a nurse, they still need people who can, exactly as Gift described, they need to be able to apply the case definition, they need to be able to assess dehydration. But if a structure has the capacity, there's staff that has the capacity to put in IVs, there has to be a different type of infrastructure and supply management and IPC, and that is called a stabilization center. So I just want to be really clear that that is what we've been really focusing on here, is this oral rehydration points that really have this, you have a different level of staff. You still need good IPC, obviously, but cholera is circulating in the community as well. So we just have to take that into consideration. 80% of patients with cholera are non-symptomatic and they're in the community. So that's just something to keep in mind. If there is a place where I support stabilization centers, which are a waypoint, as it were, if the staff has the capacity to do that, but it needs a different type of infrastructure. Thank you.
Thanks very much for the clarification, Kate, and thank you very much also, Gift, for your... In the interest of time, I mean, there are lots of questions and we could have really good discussions, but in the interest of time, we'll move ahead now to Beverly Laher and Jamie Rylance and the importance of data to improve clinical management and their project in Malawi, what they learned from that. So over to Jamie and Beverly.
Thanks, Supriya. I'm going to give a few opening remarks and then introduce my colleague, Beverly Laher. This really represents a strong partnership with the Public Health Institute of Malawi and with the Kamuzu University of Health Sciences, and happily at Geneva, WHO being able to support the data collection. I've seen 2 or 3 times in the chat just now, people anxious or willing to help with data collection to understand cholera more. I think that's very key, and I will talk about how you might be able to do that. This is our unit and how we're thinking about all of our implementation, cholera included. It's really important, like in this, that we form clinical networks on the left-hand side, and we're all aiming towards improved clinical care and outcomes for everyone in health emergencies on the right. There's lots of things we can do to make the people in the clinical network have an impact on people in the community. One of them is data, which I'm going to talk about. There's clinical guidelines, there's implementation tools, and there's all sorts of other mechanisms by which we can improve care, and training has been already discussed. I'm going to pick out, though, the WHO Global Clinical Platform, which was the mechanism by which we collected data in Malawi and in order to understand how patients were with cholera in terms of both when they came to cholera treatment centre and as they improved and were discharged. Beverly's going to show you data on this and how we think it can be important. These are small numbers. It's really difficult to do this well in a health emergency, but it's so important. And I'm going to just highlight that we are open to receive any approaches from anyone who is working or might be working in cholera treatment that wishes to be involved in data collection to improve our global understanding. Please do approach us, and I will put the website and my email address in the chat. For now, though, I'm going to pass over to Beverly, my colleague. Please go ahead, Bev.
All right, thank you, Jamie. So I'm just going to be talking about the experience from Malawi. So Malawi recently experienced a very devastating cholera outbreak, which resulted in more than 58,000 cases, with a case fatality rate of way above 1%, which is what is recommended by WHO. Traditionally, we focus on epidemiological data collection, but we do know that clinical data on patients can complement the epidemiological data and can be used to enhance care. There is some literature that is there to say that clinical data can help understand the clinical characterization of disease, the severity, and possibly inform management or care of patients. So we set out to determine really the feasibility of collecting patient-level data during an outbreak, so learning from the lessons in Malawi. Next slide, please. So how did we do this? So really, we collected data from 3 high-burden cholera treatment units in Lilongwe, which is the capital city, but it was also the hardest hit, one of the hardest hit areas in Malawi during the outbreak. So we collected information from patient notes and asking questions and entered this into WHO standardized form, which was then entered into portable electronic devices and into a software called RedCap. So here we just have a snapshot of really the admission form. You can see that we're collecting extensive data from the patient notes. Next slide, please. So to answer the question of, is it feasible to collect data during an emergency, we really looked at how much data can be collected and how complete is the data that is being collected. So data that was collected during the outbreak was really at 3 time points. So we had a separate data collection tool for admission, the review period, and at discharge. So 3 time points. And we see that a total of 258 variables were collected using these 3 different case reporting forms. Now, when it comes to the completion rate of the data, we see that there's a good completion rate overall for the admission. So you have your demographics there in blue, which is the admission form, the demographics, the vital signs, all the clinical presentation. We don't see anything on management because this is at admission, and then lots of the symptoms. And then when you look at the lab results, we don't have much there. And then at discharge, of course, you have a lot more data too. So overall, there's like 74% completion rate at admission in comparison to discharge or in total. And this really speaks to the fact that, okay, at admission, we can collect more data and it can inform the management of the patient. In comparison to other studies in similar settings, there was very limited information. We did find some studies that had tried to look at completion rates, but most of them were in emergency departments in the hospital and not necessarily during an epidemic or a health emergency. Next slide, please. So what does the data show us? First of all, some demographics, so age, gender, and recent vaccination status, so OCV. We see that a lot of the patients were in the age range of either 18 to 64 or below the age of 5, so the under 5 children category. Next slide, please. When it comes to the vital signs and clinical presentation, we see that there's a majority of the patient presenting with gastric-related symptoms. But also what we would like to highlight here is really the presentation of weakness. So 70% presenting with weakness and 10% presenting with muscle cramps, which really could speak to the electrolyte imbalances, which have been an area of interest, but has been poorly documented. And we also see about 19% really presenting with confusion, and this could possibly speak to the severity of the disease, perhaps dehydration or hypoglycemia. And we see that a lot of the patients presenting there really had moderate dehydration. So 54% presented with moderate dehydration. Next slide, please. So when it comes to the lab investigations, as we saw in the completion, in the data where I was talking about how complete is the data, that a lot of the lab investigations, we do not have that for a lot of the patients. And this really speaks probably to the capacity of the facility to do the lab investigations during the outbreak. But we did have 26 case reporting forms with lab investigations. And here we just really focused on the hypokalemia because we know that it is life-threatening and it can lead to cardiac dysfunction and possibly sudden death. So we see that 4 out of the 26 presented with severe hypokalemia, and a lot of them with mild, only 16, and about 11 with moderate hypokalemia. So a lot of there was a gap in, as I said, a gap in the lab investigations, but we just wanted to highlight this important finding. Next slide, please. So when it comes to the therapeutic management, we see that a lot of the patients were administered with antibiotics, so 88%, 92% with oral rehydration, and 90% with IV fluids. We do not present this, but a lot of the patients also were able to drink and to eat, but the frequency of the vomiting was very high. So this probably explains why we see a lot of the we'll see a lot of the patients on both ORS and IV fluid. Next slide, please. So what are we saying here? What are the key messages? So we're saying that data can be collected during health emergencies, but it does require additional people, which can be very difficult with a stretched workforce. And we can gain simple clinical insights and can direct future inquiry and improve patient care and outcomes. As you can see that some of the data was a lot of the data is very detailed. There's not much of it, but you can tell a story from it, and you can improve patient care and outcomes. And lastly, to capture follow-up data. So as you can see that the completion rate for the discharge form, so CRF 3, which was I think in orange, to capture that data, it's not easy, and to present it in real time, it's more complex. And these are areas for focus for future outbreaks. Next slide, please. Thank you. That is the end of my presentation.
Thank you very much, Beverly, for that very clear, concise presentation highlighting the importance of clinical data, and especially that it's not easy in an emergency, but it can be done. And if it can be done, it gives great insights for treatment. Thank you very much. Jamie, over to you. Anything you'd like to add further to that?
No, I think Beverly has shown it all. Philippe said at the top of the call that cholera had easy treatment. In theory, it's easy. In practice, of course, getting the right patient at the right time on the right therapy is really a little bit more complex. And we show with the data here how we can start to make the case for where we put resource, how we think about improvements in care, and actually measuring the quality of care. It's been discussed in some of the questions already about why people die in treatment centres. It's really important that we focus in the community on getting people access to oral rehydration and the ORPs, and when they absolutely need it, get them to a facility on time, and when they're in the facility, to get high quality care. And I think data is one of the things that's going to help us to do that.
Thanks very much, Jamie. We have about 10 minutes left and lots of questions, so we will go on to more Q&As. But very quickly, I just wanted to show the response we had to the question earlier. How many of you are currently or have been in the past involved in cholera outbreaks? So a fair number, almost half of you have been involved in cholera outbreaks, but nearly half have not. So I hope you find this useful, and I hope you have a role next time as well. So with that, I'd like to move on to some of the questions. There's so many. There's one that I thought was very interesting, and I will, which talks about the community and especially about stigma. How do you manage stigma and discrimination, which is a key part of communities in so can I ask Vicky and Gift if they'd like to respond to that? Vicky, would you like to go first and to talk about managing stigma in cholera patients?
Yeah, so thank you for the question. That's a really important one. And I think, as it was mentioned throughout the webinar, is the importance of working with the communities from the beginning. And especially, like Philippe was also saying, is to include the most vulnerable from the beginning of the outbreak, and working with the trusted representative of the community's trust is really essential here. Like it was saying too, like it was said, is the importance of access to care and giving the possibility to everyone in the community to be able to seek care. So I don't know here if Gift wanted to add something. She had a great slide where she was mentioning the success of ORP in communities. So Gift, I don't know if you wanted to add something with especially the, the concrete experience you had with ORPs. Yeah, one thing,
yes,
one great point I think you were saying is really involve the communities to discuss with them what the locations so that it's accessible to them, right?
Mm-hmm. Yes, Vicky, that's very true. The first thing is to involve the community in selecting where the ORP should be and the volunteers who are going to be managing the ORPs. That itself, it gives access to those in need, and they build trust in the community because they know these are our own people. We are living with them day in, day out. So they trust them, they believe in them. So they won't have problems with that. But using strangers to manage ORPs, they would be say, probably they will have something to say behind my back, right? So the most important thing is put ORPs at the center of the community and let the community own it. Thank you.
Thanks,
you, Gift, Gift and Vicky. So, yep, put ORPs at the center of the community. Anything else you'd like to add, Vicky? Thank you very much. So the next question, there's a question on from Isatu Sar on what are the barriers to accessing cholera treatment services in resource-limited settings, and how can these barriers be addressed to improve outcomes and reduce mortality rates? Kate, Jamie, would you like to take that?
I can certainly start. Thank you very much. I think one thing we do have to remember, of course, is that cholera is only occurring in areas with low socioeconomic, situations. Otherwise, they would hopefully have access to clean water and sanitation. I think for me, as we've said, you really have these two streams of work. One is in the treatment structures, and we have more work to be done there and the research, and that's what Jamie and Beverly presented. The other is this access to care. And I think it's something, again, that is potentially underestimated, is the role of this community care and ORPs, so that the patients that you can focus the energy and the resources on patients who need to be hospitalized in those hospital structures, but keep the patients who don't need to be there out of them and stay in the community. I think all of the elements that Gift shared in terms of remaining in the community, a better potentially faster care seeking, because you're not having to go out of your community, you're staying in an area that's very familiar with people familiar. And although there is investment to set them up, I think in the long run, they're much less expensive. I think the other thing that we don't always, we haven't, there've been waves. There was a lot done some decades ago, and there's a little less emphasis on it now, is working in areas that are at risk or communities that are at risk when you're not in an outbreak, and ensuring that those key messages about starting ORS, about hygiene, about all those are in those communities as part of the whole prevention package. We know that it's going to be a long time until we have, unfortunately, we would all love to see it, safe water into all the communities. But I think that's part of it. And there used to be something called oral rehydration corners in every primary healthcare structure and even health posts in many countries that provided ORS. And this is really just, many of them, they no longer exist. But I think the community, as was said by Vicky and Gift, the community is really at the heart of all of this. And there are a lot of solutions out there that you don't see from the exterior. And that's where the solutions are going to come from. But there might need a bit of support, and we need to be listening. I'm not sure that answered the question. If anybody else wants to jump in, please do.
Jamie, do you want to add anything to that?
No, I think Kate's captured it. I think it's important that care is provided closest to the communities, and that it's trusted, and Gifted a very good explanation of how to ensure that that's the case in what can be very disparate and geographically remote areas, but where care is absolutely required in the same as anywhere.
Thank you. Going through these questions, I see some of them are very, very specific technical questions, and perhaps we could send them to Jamie and Kate and Gift and Beverly and respond to you specifically on that. But there are a few questions that might be relevant, like questions around community death. Mandla's one is that how do you deal with community death and classify them if they were not tested for cholera? There's another question also as, if someone dies within 4 hours, if a patient dies within 4 hours of admission, is it considered community death and not an institutional death? So there are questions on definitions and how to, who would like to take that? Jamie, you or?
So many questions and almost
Yes.
negative time, Supriya. Well, I think the death, nobody wants deaths anywhere. Deaths in the community are a tragedy because they mean that there is a lack of access to care at ORPs, basic rehydration therapy or rehydration salts, and then or lack of access to cholera treatment centres. So the deaths in the community, there's always much less known than in the facilities because they're less supervised, there's less medical understanding immediately where the patient or person has died, and so we have a lot less information. What I think we know is how to prevent those deaths in the community, and Gift has talked really much about how we ensure trust and move people through the system into treatment facilities where they need it, and then we can focus on the more biomedical understanding of what's going on. But it really is sociological and about community trust in the first place in terms of solving the problem of community deaths.
Thanks, Jamie. Beverly, would you like to also say anything?
No, not at the moment. Thank you.
Thank you very much. There are questions also on training materials available. Are there training materials available for ORP workers? From David Schiff, they'd like to have training in community health workers and volunteers in ORPs. And there's a request for an assessment tool to set up ORPs. So clearly a lot of interest there. In the interest of time, I see that we're over time, actually. Perhaps what we will do is answer as many of these questions in the form of an FAQ and send it to all those who attended today so that you get your questions. We also, we will be setting up a small WhatsApp group for this community so you can learn from each other. So before we end, I'd like to request Nedret if she has any final remarks from this webinar.
Thank you so much to all of you for your contribution and questions. As mentioned, we will come back to you. But I'd like to also introduce Dr. Janet Dias, who is leading the safe and scalable care within WHO. By default, acting in health emergencies. By default, she has been leading the emergency case management for cholera. And would you like to say a few words, Janet, before we close?
Thanks, Nedret, and good morning, good afternoon, good evening, colleagues. It is a pleasure to be here, and I was very excited to hear the colleagues all present today, especially the colleagues from Malawi, where I was spent a little bit of time those early days of that at the beginning of that outbreak. So just to highlight some key points here, and as Philippe probably started with, it's easy, but not necessarily so easy, but they are simple interventions. And I think we have to remember, and some simple ways that I think about this, not just for cholera, but for other health emergencies in trying to deliver the right care to the right patient at the right time, is the 4 or 5 S's. Remember, you need safe structures. So the structures that when you're working in, that they're safe and they're built right so you can safely take care of your patients and the communities accept these structures. You need staff, you need skilled workforce. So the staff that's working, taking care of the patients in the community or in the treatment facilities, that they are skilled and they're trained. You need supplies. So basic medical devices and equipment necessary to deliver that care. So those are the basic things, but they need to be there to do your job. And you need systems. And systems start here in the community, as everyone has, as was really nicely said by Gift, how the community interventions are really #1 for early recognition and early treatments. And then systems of referrals to treatment centers, and then systems for data collection. So you can do what the colleagues in Malawi did, is collect data that can guide treatment, especially for those patients that are more complicated and more severely ill. So with that, go back to the basics. We can do these basics well. We know that this area is underfunded, sometimes under-recognized how important it is, but I think together with all the partners, with all the colleagues on the ground, all the health workers, all the community workers, that together we are able to achieve a lot. So I think just mostly a thanks to all the colleagues, and it's great to hear this, and look forward to continuing to work alongside of you all. Thank you, and I wish everyone a good day.
Thank you very much, Janet. Sorry, Nedret.
So once more, thanks to you all, particularly you sharing your country experiences with us, which is extremely valuable. And we are here to support you. As mentioned, please send your questions, comments, and we will try to connect with you. Back to you, Supriya, to close.
Thank you very much, Nedret. Thank you for your leadership and your guidance and your support through this. Thanks also to Janet and to the whole team. Thank you to Philippe and Kate, who have made time for this webinar in spite of multiple emergencies that are ongoing, and to Gift and to Beverly, whose work is so important, and they took the time to present. But most of all, thanks to all of you for attending today. And I just share my screen right now with the you'd asked for more information, and I am just sharing my screen with the information that you asked for on more resources. So here is a link to the GTFCC website and to the Cholera app. There's a Cholera app, and you will get lots of information there as well. So we will share this with you also by email in response, but please do reach out there. And thank you once again for joining all of us. And an announcement also for the next event that we are going to be having is we have an ad hoc event on Monday at 1 p.m. on H5N1 in dairy cattle and the public health risks of that. So please do join us there. You will get the invitation as usual. And in the chat, you have the link to subscribe to EPI-WIN so that you get all the announcements. Thank you very much once again, and see you soon. Hopefully, we will see you on Monday, the 6th at 1 p.m. Geneva time for the next EPI-WIN webinar. Thank you. Bye.